Welcome to the NWAETC Project Echo. I'm Kent Unruh. I'd like to turn it over to our medical director, Dr. Brian Will, to introduce our guest.
Well, I'd like to thank Dr. Stephanie Page for being with us today and for tackling this topic, which comes up a lot in our clinic. Dr. Page is section head of the Division of Endocrinology here at Harborview and does a lot of androgen-related research, and I will turn it over to her.
Great, thank you. Thanks for inviting me. I'm always happy to talk about anything related to testosterone, so believe it or not. So things I want to touch on today in this session are the definition and diagnosis of hypogonadism. And just to preface all of this, I'm really going to just be talking about men today. And then the prevalence, and point out some of the issues with regards to prevalence in the HIV-infected population, and go over how in endocrine we make the diagnosis of the various types of hypogonadisms. Then the other big issue is what are the risks and benefit of replacement once you've decided to consider treatment in an individual who you've diagnosed with hypogonadism, and then what are your options in terms of delivery and safe, and how should you monitor correctly for safety. So why do we care about this? Well, I'm sure you have patients that come in and with all the direct marketing advertising that's going on now for various forms of testosterone, I'm sure patients are asking, but one of the reasons that we care about this in terms of the physiology is that androgens really have widespread effects in men, many of them positive. So we know that androgens, and now I don't know if any of you saw, there was a very interesting New England Journal article that also implicated really quite substantially estrogens and some of the androgen effects, but we can talk about that during the question period if you wish. But the androgens really have some very positive effects on muscle. They also decrease fat mass, those things that we think would be very beneficial metabolically for our patients. There are some significant effects at the brain in terms of mood, sexual function, and of course, this is mostly geared at post-pubertal men, so we won't talk about the important developmental effects. Also, things that are important in people with chronic illness, they can have some significant effects on erythropoiesis, which could be a risk or a benefit depending on an individual. So as men age, androgen levels go down, and all of the things that I'm pointing out in this diagram are affected both by age itself and possibly by decrements in sex steroids. What about HIV-infected individuals? So it turns out there actually aren't that many good cross-sectional analyses of the prevalence of HIV in the post-heart era in HIV-infected men. But my review of the literature really suggests that hypogonadism is more common in HIV-infected men. It's probably about 20% of the population of men between the ages of 40 and 65 who are infected with HIV, which is more than we would see in a non-HIV infected population, but not necessarily more than we would see in a set of individuals who have chronic illness. So the biggest risk factors for the development of hypogonadism are age. We know that testosterone levels decrease approximately 1% per year in men over the age of 25. So far and away, the biggest risk factor for the development of hypogonadism is age. Obesity is a significant risk factor as well, and I'll talk about that in a minute, and chronic illness as well as a number of others. And so one question that always comes up is, should we be screening men for hypogonadism? Is particularly, again, since there's all this marketing of testosterone now, and really the recommendation is not to screen men for hypogonadism. If you look at the most recent guidelines from the Endocrine Society, there is a caveat to consider screening men who have HIV-associated weight loss, since there have been some trials suggesting that there may be a benefit in those individuals. But I would leave that to your discretion. And of course, HIV-associated weight loss has significantly declined in the post-heart era. So what are the signs and symptoms of hypogonadism? Why would you want to consider checking a man's testosterone level? Well, oftentimes, of course, men come in with sexual complaints, particularly as they age. And it turns out the most sensitive complaint actually for hypogonadism is a constellation of decreased libido, erectile dysfunction of some nature, and decreased morning erections. So there was a nice cross-sectional analysis, and that's the most specific sign for hypogonadism, but again, much overlap. Many individuals with those complaints have perfectly normal testosterone levels. Men may complain of gynecomastia, which is usually to do with estrogen having a more predominant effect in the low androgen environment and decreases in their male pattern hair. And then some very nonspecific complaints, but complaints that we all see in all of our patients: lack of energy, fatigue, moodiness, difficulty building muscle mass, increases in fat mass. Those can all be sensitive. Those are all things that can be sensitive to androgens, but again, are very nonspecific. And lots of studies in this area have looked at the overlap between all of these complaints and the biochemical criteria of low testosterone levels. And unfortunately, the overlap is not very good. So what to do in the face of that data? When a man comes in who's complaining of one of those issues and you're considering the diagnosis of hypogonadism, the first thing you want to do is check a serum testosterone level. So that's down here in number 1 here. And so we don't make the diagnosis of hypogonadism based solely on one single serum testosterone level. So if the level is low, you need to repeat it, and the recommendation is to do it in the morning and to do it fasting. One issue that's very important, particularly in providers outside of Seattle, I would imagine, is that your reference laboratory uses a good test. And so there's a lot of controversy about testosterone assays, but the bottom line is you want to be sending to a big lab that uses mass spectrometry, liquid chromatography and mass spectrometry to measure levels. Some of the platform assays are notoriously poor at measuring testosterone. So you check a level and can either have a borderline level or a low level. And so what you want to do next is try and figure out where the defect is. So like many things in endocrine, there are feedback loops, and the thing that regulates testosterone production in the testicle the most are gonadotropins, so particularly LH and to much lesser extent FSH. So the diagnosis of primary hypergonadism is a testicular defect where you lose negative feedback to the brain, and therefore FSH and LH levels are very high. So this is what you would see in an individual, for example, who'd had radiation, who'd lost a testicle, or had something else going on that's blocking production of testosterone at the level of the testicle. Much more commonly in post-pubertal individuals, you will either see secondary hypogonadism or what we call late onset hypogonadism. And these are individuals that will either have very low gonadotropins, which is what we see in secondary hypogonadism, where the level of the defect is at the level of the brain, or what's called late onset hypogonadism, where the LH levels can be low or normal, but for the low level of testosterone are not appropriately elevated. And so we think this is a defect in the communication between the brain and the testicle. These are the things you want to check after you've gotten a low testosterone level. The other thing that's very important in HIV patients in particular, and in any patient who really has obesity, which is many of our patients now, is to also check a free testosterone level. And this is something that you can do with all of your reference laboratories. We recommend getting a calculated free testosterone level because again, with some assay issues with many of the assays to measure free testosterone. This is really important. Because of the fact that most testosterone is bound, and it's very tightly bound to sex hormone binding globulin. Sex hormone binding globulin levels are very much affected by obesity, by androgens themselves, by estrogens, and also by HIV. So it's important, I think, in this particular population that you get a total testosterone level and that your reflex panel also is to get a calculated free testosterone level. So really to make the diagnosis of hypogonadism, you need to have both a combination of symptoms, and it's not that hard in most middle and older age men to elicit some symptom of hypogonadism, probably what prompted you to do this in the beginning, and then to have biochemical evidence. We don't generally recommend treating people based only on a laboratory value, and that gets into the risks and benefits of therapy. And again, to get a calculated free T level in the evaluation. The high LH level reflects a testicular defect. The low LH level reflects a secondary defect. So in terms of secondary hypogonadism, the other thing, what you really want to think about, and this might be a point at which you would refer the patient to an endocrinologist if you could, or get some additional help. But what you're really looking at then is there a defect in the pituitary? So you would look at other pituitary hormones, including TSH and thyroid hormone. You might consider getting a pituitary MRI at some point. There's not really an indication that pituitary disease is more common in HIV patients than in other individuals, but that would be a next step in the diagnosis of secondary hypogonadism. You might screen for hemochromatosis, and particularly in HIV populations, you really need to ask some very critical questions about the use of anabolic steroids. So use of exogenous androgens will present like secondary hypogonadism in terms of the biochemical evaluation. So you want to do a very good physical exam then if this is a really buffed guy and they're coming in to ask these questions. You really need to think about previous anabolic steroid use or current use, and we see more and more of this in our patients, particularly in young men who may have been exposed to anabolic steroids as high school students. It's a lot of use in high school athletes now. And then the other things that you really need to think about are use of opiates. So men who are on chronic methadone, opiates affect gonadotropins, so affect LH and FSH production, and that will present like secondary hypogonadism. In terms of treating individuals, if they're going to be on long-term opiates, it's a consideration to replace their testosterone. Chronic illness will also suppress gonadotropin production, as will malnutrition, and of course aging, as I talked about. There's a much higher incidence of this lowish LH hypogonadism. What about if you've made the diagnosis, what are the risks and benefits of giving men testosterone therapy? So the most important take-home message about testosterone therapy is we do not know the risks and benefits of long-term testosterone replacement. There has been nothing equivalent to the WHI with all of its caveats for men. So despite the fact that millions and millions of dollars are spent on testosterone therapy every year, we do not know the long-term risks and benefits. So what do we know? So in the short run, we know that testosterone therapy really does increase lean mass. That's why the athletes like it. It does increase bone mineral density. It can have positive effects on libido and sexual performance. That's really a plateau effect. So once people achieve testosterone levels in the normal range, increasing the dose of testosterone will not increase their sexual performance. That's something important to talk to patients about. It does increase hematocrit, and androgens do decrease fat mass. But what about more clinically important endpoints? What about strength, physical performance, quality of life measures, for example? The results of the randomized clinical trials, and these are in non-HIV infected individuals, are pretty mixed still in those kinds of measures. So I think I would summarize the literature as saying in the non-HIV infected population, we do see some increases in leg strength with androgen administration in men with low testosterone levels. We do see these important changes in body composition, but we have not been able to show that this results in improvements in insulin sensitivity, as you might expect, or real improvements in lipids. And it's also very important to know that the benefits of testosterone therapy in all the randomized clinical trials really are mostly seen in the men who start with the lowest baseline testosterone levels. So men who have these lowish T levels and you give testosterone to may not have as much of a benefit as some of the people who start lower. So what are the risks? So again, we don't have long-term data to really know. I would summarize what we do know in non-HIV infected individuals as saying that really the randomized clinical trials have not shown a significant increase in significant adverse events, with the exception of one trial, which was stopped early and showed an increase in cardiovascular events. But that was in a very unique, elderly, very immobile, very sick population. There is the thought out there that testosterone increases the risk of prostate cancer. That's really not borne out by the literature. PSA is an androgen-sensitive gene and protein, so you do see some increases in PSA when you give men androgens, but there's been no real hint that there's an increase in prostate cancer incidence when androgens are given. Cardiovascular disease is also unclear. We know that giving androgens will lower men's HDL. It also lowers their LDL and their total cholesterol, so we don't know the long-term risks associated with for heart disease, and this is a big area of research right now. Again, it can be a risk, of course, to increase men's hematocrit, and I will point out that with the exception of injections, testosterone therapies are quite expensive. So what about the big endpoint? What about testosterone and mortality? Well, again, we don't have an appropriate randomized clinical trial. There have been a number of very large prospective studies that have been published in the last 5 years that have suggested that men with low testosterone levels have earlier mortality than men with normal testosterone levels. And this is using multivariate analysis and trying to control very closely for other risk factors, in particular health status. which could be the reason that people have a lower testosterone level to start with. That being said, there have been a number of these trials, so we do think from observational data that having low T may be bad in terms of mortality. And this graph I'm showing you here is really the newest of these sorts of data, a little bit more interesting, where this is from actually the VA here in Seattle, where they looked at individuals, these were 1,300 veterans who'd been diagnosed with hypogonadism, and they looked at them over a 4-year period and found that the individuals who had actually been treated with testosterone had a better survival than those that had not. So this is as close as we have to any kind of intervention data and mortality, but it hints that perhaps it might be beneficial. Again, I would not take away from this that testosterone has a mortality benefit in men with low testosterone, but it's some interesting data. So what about men with HIV? This is a meta-analysis of the 7 randomized controlled trials of HIV-infected men who were treated with testosterone. And this is looking at lean body mass as the clinical endpoint. So again, we have these non-performance-based clinical measures that are really the readouts for most of these trials. So there are 7 trials, and overall there was an increase in lean body mass in the men treated with testosterone compared to those treated with placebo in these trials. These trials are incredibly limited. They are all small. None of them enrolled more than 100 patients. They're all short, none longer than 6 months. And really all but one were done, all of them were done in men who had HIV-associated weight loss. So the goal here was really to use testosterone as an anabolic agent. And only one was done in the post-heart era of all these studies. So, and again, we're not really talking about a functional outcome here. So the older data, which you may have been familiar with, suggested that testosterone might be good for in the case of HIV-associated weight loss. But again, even this is some fairly limited data. There was a very nice, interesting trial actually done by Shally Basine, who does a lot of these androgen trials. And this is the only study in the post-heart era. So all these men were on heart, and they were given 3-fold the normal replacement dose of testosterone. So this is really trying to use testosterone as an anabolic agent. And you can see that there was an increase in fat-free mass, which is lean body mass, a decrease in fat mass, mild increase in weight. But really in all the functional outcomes, even though the men who received testosterone improved from baseline in some functional outcomes such as strength, compared to placebo, there were no statistically significant improvements. So even using testosterone as an anabolic agent in this population may not be that beneficial. So going back to the beginning of the talk, if you have diagnosed one of your patients with hypogonadism, I would treat them just the same way as a non-HIV infected individual in your discussions about offering testosterone replacement. The formulations that are out there that are safe to use do not use methyl testosterone. That's associated with hepatic toxicity. So no oral formulations are available. We'll probably see those in the next couple of years, I think, but not right now. So the injections are very cheap. They are big needles. It's an oily formulation. Men can be taught to do this themselves. Usually they give it in the hip or in the buttock, or they can have their partner do so. The injections are fine to give every 2 weeks. You can give the half dose every week as well. Some individuals like that better. Subcutaneous implants are also a possibility. Those are an in-office procedure. They're expensive, also not any cheaper than the gels, but they do give nice continuous levels. The gels are very popular for the companies that market them. Patients actually really like them. They cost about $300 a month. So this is very expensive stuff. People's insurance pays for it. That's great, but not all insurers will. It is kind of messy. It smells not great. Some people like the smell. But it's very important that patients that use the gels wash their hands. If they are dealing with children or have children in their house, they need to keep it locked away. You should follow patients. You should get a hematocrit at the beginning. It's controversial, but we're still recommending getting a PSA at baseline. The whole issue of PSA is, of course, a quagmire and hours and hours of talk in and of itself. But I think in individuals you're going to give androgens to, what you're really worried about is turning on clinically undetectable prostate cancer. And we don't really know if we will do that, but that's the risk. So getting a baseline PSA, and then there are some guidelines about when to consider getting a prostate biopsy if you see a big jump in PSA. So you expect to see a little bit of an increase in PSA, no more than 1.4 milligrams per milliliter per year. If you see more than that, you have to probably send them to a urologist. So in summary, the incidence of hypogonadism is probably higher in the HIV-infected population than in non-HIV-infected men, but really the biggest risk factor is age. The diagnosis is based on symptoms, low testosterone levels, and really trying to figure out if this is at the level of the brain, at the level of the testicle, or is somehow associated with age, or some other communication between the two. In the HIV-infected population, when you're trying to figure out what's going on and why they might have low testosterone levels, you really need to think about anabolic steroids, opiate use, and any other illness that might be contributing before you make the diagnosis. Testosterone therapy, we don't know the risks. We know you can have some probably important effects on body composition and sexual function, mostly libido. It is not a cure for erectile dysfunction, and maybe some improvements in quality of life, but there are some pretty important financial considerations. And so one thing that I really think is important, once you start a man on testosterone, it's an expensive medication that they could potentially be on for the rest of their life. So it's important to think about and ask them, do you feel better? What's better? And document that and really think about it, because you're putting them on a lifelong medication and you want to be able to understand what benefits they might be experiencing.